Now let's perform L5 S1 local traction. We start out with a local traction technique in order to prepare the joint for further gliding. In this case, we're dealing with a painful L4, L5 segment that is painful in the direction of extension, and a hypomobile L5 S1. So we'll perform traction and then follow it with an extension glide at L5 S1. In order to perform the traction at L5 S1, we're first going to pre-position L4, L5 and up out of extension, because this patient doesn't like extension. To do so, I'm going to put palpating fingers on the segments of L5 S1 and L4 L5 with the patient positioned having the break in the table halfway between the segment that I'm treating and the lower thoracic spine, approximately T8. I'm now going to palpate L5 S1 and L4 L5, reach under the patient, and I'm going to first flex her down through L4 L5, allowing L5 S1 to stay in a neutral position. I do it by pulling the shoulders down towards the belly button. This also allows for flexion of the head and neck. I'm going to now reach down and place the sky side leg behind the mat side leg. And this is going to allow more clearance for the rotation that I'm going to try and produce. Then, in this position, I'll reach under the patient, and in this flexed preposition, I'm going to now rotate and side bend the patient to achieve that prepositioning that we spoke of earlier. In this position, I may need to ensure the flexion at L4, L5. So I might pull her forward into a little more flexion. Sometimes when you rotate the patient, they lose a little bit of that flexion. In this position now, I'm going to keep her sacrum vertical, place my mobilizing hand over the PSIS on her right side. I'm going to stabilize the L5 spinous process on its sky side with my mobilizing hand to PSIS and the forearm over the greater trochanter. I'm now going to produce a rotation in the pelvis and S1 by pulling the PSIS and creating pressure over the greater trochanter in a ventral caudal direction, in the direction of the greater trochanter. In so doing, I'm going to separate S1 from L5 in a direction that's perpendicular to the orientation of the joint surfaces of the zygapophyseal joints. Stabilize L5 on the sky side, grasp PSIS, forearm over the greater trochanter, and now the oscillatory motion is like this. I start out with oscillations, preparing the joint, reducing the viscosity in the fluid, improving the mobility of the joint, and beginning to address any limits with hysteresis. After up to several minutes of this mobilization, I can then hold for 30 to 40 seconds, allowing creep to straighten the wrinkles in the collagen of the capsule around the joint. After 30 to 40 seconds, I can let off and repeat a 30 to 40 second hold for up to 5, 6, or even 7 repetitions. Afterwards, I will return the patient, release slowly, return the patient to neutral, and retest the segmental mobility. If we notice that the mobility of the rotation of the segment is not sufficient, then we can reverse the legs, putting the sky side leg above, the mat side leg behind and ensuring that the patient still maintains flexion in the segment with that new positioning. Here we can continue the treatment in the same direction. Finally, here we are emphasizing the right side. We will want to choose to repeat the same treatment of traction followed by extension gliding on the left side, so we improve total extension in the segment.